Guys, let's discuss most beautiful topic, shock. I think most of you, when you are posted in trauma, you would have seen a patient, a young male, 26-year-old male, coming with BP of 60/40, pulse rate of 130 beats per minute, all your surgery residents running by the side of the patient body. Imagine, everything what body does in that patient, and you do all the actions according to how this mechanism happens. Imagine the body is trying to vasoconstrict and you are vasodilate and you're giving the drugs to vasoconstrict. Imagine the body is having leaky capillaries and pushing all the fluid out into the tissues. Imagine you in replenishing the fluid with IV fluids. So everything the body is trying to damage, you are counteracting it. So it's beautiful how the physiology happens in the body and how we predicts, okay, this might go wrong, this might happens, and we counteract it. This is a beautiful mechanism of shock. Let's discuss about shock. So what is shock? Shock is a state of low tissue perfusion. It's a state of low tissue perfusion that is not adequate to maintain cellular respiration. Matlab, the cell is not able to respire properly. The cell is not able to respire properly because the tissue perfusion of the cell is not proper. That is shock. So what happens in shock? So there is no perfusion. So if there is no perfusion, there is decreased oxygen and there is decreased glucose. If there is decreased oxygen, decreased glucose, the cell undergoes anaerobic respiration, and cell undergoes anaerobic respiration, lactic acid gets accumulated. If cell undergoes anaerobic respiration, there is low ATP. So you all know sodium potassium pump. The sodium potassium pump needs ATP to act. So sodium potassium pump doesn't function. So what happens? The lactic acid gets accumulated. All the water balance doesn't happen properly. So the lysosome get activated. When the lysosome gets activated, the inflammation starts to set in. What are the inflammatory mediators? The complement, the coagulation pathways, all this gets activated. So then what happens? This causes endothelial injury. All the triad of the endothelial injury. The endothelial injury happens, all the fluid inside the endothelium, this endothelium cell gets getting damaged, na? So all the fluid which is present in the endothelial goes out, all the fluid goes out, and it forms edema, tissue edema. So it causes leaky capillaries and it causes tissue edema. So what happens more? The lysosomes gets activated. The lysosomes get activated. So obviously cell death happens. Intracellularly potassium is maximum. So all the potassium comes out, which causes hyperkalemia and also acidosis. Okay. So what happens in shock? Let's discuss very fast. In shock, shock is nothing but it's a tissue perfusion. Imagine the tissue needs 100 molecules of oxygen. The tissue is not able to get only 10 molecules. So that the cell is not able to respire properly. So there is no perfusion. So decreased oxygen. So decreased glucose. So anaerobic respiration starts activated. So lactic acid gets accumulated. Okay, fine. The lysosomes get activated. So inflammation starts to set in. The coagulation and complement pathway gets activated. So the endothelial injury happens. So the leaky capillary happens, and the fluid accumulates outside because of the leaky capillaries. And because of these lysosomes, cell death happens. The intracellularly potassium is maximum. So intracellularly potassium, whichever this is present, comes out. So there will be hyperkalemia and acidosis. So what happens? Let's see about systemic manifestations of shock. So forgive my crazy diagrams. Okay, this is your heart. Imagine this is your heart. So how does heart function? This is right atrium, right ventricle, left atrium, and left ventricle. This is IVC and your superior vena cava, which brings blood to heart, and this is your aorta. So what happens? Whatever, this is called as preload and this is called as afterload. Okay? Preload and afterload. Afterload is nothing but your cardiac output. Cardiac output. So imagine in shock. Imagine a person came. Imagine a 60-year-old male came with a history of RTA, and patient has lost of 1 liter of blood. So he lost 1 liter of blood. So imagine a person has 5 liters of blood. He lost 1 liter. So this becomes 4 liters. So inside body there is only 4 liters of blood. So what happens to the cardiac output? So the cardiac output decreases. So that's what happening. See, so preload, this cardiac output is decreasing. So imagine in shock, in pathophysiology of shock, you had read about leaky capillaries. So tissue edema, and this also what happens, all the fluid is going outside the capillaries. So whatever the intravascular volume, it gets decreased, na? So again what happened, cardiac output decreases. So edema, leaky capillaries or hemorrhage, what happens, the preload decreases. What happens if you decrease preload? What is preload? So imagine, because of the leaky capillaries, all the fluid is going out, the amount of blood which is reaching to heart, which is nothing but preload, it falls. Because in hemorrhagic shock, the blood is getting lost outside, whereas in other types of shock, there is leaky capillaries and the fluid is getting lost into the tissues. In any type, whatever happens, the preload is getting decreased. So what happens? So what does body thinks? Body thinks, arre, the heart is not able to function properly. We have to do something so that all the fluid gets reserved. Matlab, our fluid should not get lost. So what will body do? What is the beautiful mechanism of body? So this is the capillary. All the fluid is getting lost in capillary. So, okay, what does body does? Body does, array, let's constrict it. Let's make it chota. So the blood loss will get decreased. And what happens? So this is an artery. Artery is bleeding continuously bleeding in trauma. So what does body does? Array, let's constrict this artery. Let's contract this artery so that the bleeding decreases. So vasoconstriction happens. Vasoconstriction happens. That only I have explained. See. So what happens? Edema, leaky capillaries or hemorrhage, the preload decreases. Preload is nothing but amount of blood going into the heart, so that the cardiac output, amount of blood going out of the heart also decreases. Catecholamine starts, it causes vasoconstriction and also tachycardia. This is the exception is septic shock. We'll read when it comes to septic shock. Okay. So okay, I also want you people to know how does this preload and afterload works. So afterload mainly depends upon systemic vascular resistance. Okay, how does the systemic vascular resistance works? See, so this is heart. This is your aorta. Okay, so imagine there is a bridge. This is the bridge. So imagine there is a bridge. You know there will be gates for a bridge. Bridge matlab dam. So normally water flows into the dam. So imagine that's how the blood is going normally aram se to every part of the body. Imagine there is vasoconstriction. So in vasoconstriction what happens? This vessel will become small. Vasoconstriction means. So what happens? Imagine the water is flowing normally and the gates are अच्छे से open. So there is no resistance for water to go across the dam. So whenever the resistance is low, water goes freely. Imagine when the gates are closed. Gates close हो गया, डैम का gates close हो गया. So what happens? So the water has to try hard to push the gates and move forward. The same thing happens. Imagine this, when vasoconstriction happens na, the heart has to pump to, because this vessel is getting constricted na, to go into this constricted vessels. So when resistance increases, the work which has to be done by the heart also increases. So what happens? Imagine when vasoconstriction happens, the resistance increases. So heart has to do more work. So see, afterload depends upon systemic vascular resistance. Remember this point. So what more things happen? So you know lungs na, what happens with lungs? We have discussed about the heart. So you all know the metabolic acidosis starts happening, and we also have seen sympathetic output also starts increasing. So what does this do? This increases the respiratory rate. This increases the respiratory rate. Why? To compensate this metabolic acidosis, the body is increasing respiratory rate so that the whatever carbon dioxide is getting accumulated goes out. So it is what is body doing? It is doing compensatory respiratory alkalosis. So metabolic acidosis developed. So body is compensating by respiratory alkalosis. How beautiful the mechanism, see. So whatever happens to kidney, you know, kidneys, what happens to kidney? So perfusion to the kidney, obviously all the fluid getting lost into tissues, or all the fluid is getting hemorrhaged going outside. So perfusion to kidney decreases. Along with it, the catecholamines, your catecholamines also starts acting. So the GFR decreases and the urine output decreases. So it causes vasoconstriction. The RAS, renin-angiotensin aldosterone system gets activated, and it causes vasoconstriction, and it, so body thinks, are all the water is getting lost into the tissues, or it's going out as in a form of hemorrhage. So my body needs some water, so it causes water retention. Kidney causes water retention. So this is basic pathophysiology of heart. So, of shock, see what happens. Heart, so the preload decreases, so body thinks all my fluid is lost. So what it causes? Catecholamine release. What does catecholamines do? Catecholamines does vasoconstriction. Vasoconstriction. What does lung happens? Lungs does increases the respiratory rate. Why does it increase the respiratory rate? Because of anaerobic respiration, lactic acidosis and metabolic acidosis got set up it now. In order to compensate this, lung does increase respiration, so there will be compensatory respiratory alkalosis. So what does kidney do? Kidney conserves its water and does vasoconstriction. So this is basic pathophysiology of shock. So okay, let's discuss about different types of shock. I already discussed about this hemorrhagic shock, blood goes out, the cardiac output decreases, all that. In hypovolemic shock also, it is decreased circulating fluid. It can be because of dehydration, pancreatitis and diabetes insipidus. So what is obstructive shock? So these are the different types of shocks. One is hypovolemic shock, obstructive shock 2, cardiogenic shock and distributive shock. Let's discuss different types of shocks. Hypovolemic shock done. Then what is obstructive shock? So imagine there is cardiac tamponade. So imagine this is heart and here blood got accumulated. So this is pericardium and this is heart. So here blood got accumulated. So what happens? The heart is not able to pump properly because of this accumulated blood. Okay, and cardiac tamponade and tension pneumothorax. Imagine there is pneumothorax, so that the intrathoracic pressure gets increased. In massive pulmonary embolism also, intrathoracic pressure is increased. So the heart is not able to pump blood normally. So the physiology is same as that of hypovolemic shock, which is decreased cardiac output. Because why? Because the heart is not able to pump properly. Okay? Yes. Then what is cardiogenic shock? Same. This is obviously the damage to the heart. Here the heart is intact, but the things around the heart which is needed for proper pumping is not good. But here na, heart is also damaged because of myocardial infarction or myocardial depression because of bacterial toxins. What happens then? So imagine the heart is not able to pump. So the preload is good. All the blood is coming to heart, but heart is not able to pump. Then what happens? All the blood gets accumulating in the heart. All the blood gets accumulated in the heart. Heart is not able to pump properly, na. So blood accumulates in the heart. You know, blood comes by inferior vena cava, so inferior vena cava into right atrium, then goes into right ventricle, then goes into lungs for oxygenation. So blood is going to lungs also properly, and from lungs also blood is coming. But after it's not going to pumping, so after that it's not able to pump properly. So what happens? All the blood accumulates into pulmonary vessels, in the body, everywhere. So there will be pulmonary edema and there will be pulmonary venous hypertension. How beautiful is this? See. Fourth one is distributive shock. In distributive shock, there can be sepsis, there can be anaphylaxis, and there can be spinal shock. How does this act? See, in sepsis, you all know gram-negative bacteria decreases endotoxins. What does this endotoxin causes? Again causes capillary injury, endothelial injury called as leaky capillaries. We already had that. So endothelial injury, again leaky capillaries. Yes. Second thing is anaphylaxis. What happens is anaphylaxis? In anaphylaxis there is instant vasodilatation because of this histamines, mast cell, all these release. So histamine release, there is vasodilatation. So see, in all these in all the hypovolemic shock, cardiogenic shock, the cardiac output is decreasing. Okay? Okay? And here, see, will explain. And tisra is septic shock. Sorry, spinal shock. What happens in spinal shock? There is no sympathetic output because now at T4, T5, the injuries happened from where the sympathetic output comes. So there is no sympathetic output to the body. So whatever you are telling, the vasoconstriction happens. In the pathophysiology of the shock we have read, the vasoconstriction happens. The vasoconstriction happens. Here we have studied vasoconstriction happens. All this doesn't happen. That's why we have read the exception for vasoconstriction is septic shock, because the compensatory mechanism never acts. Why does compensatory mechanism never acts? Because there is no sympathetic output. Okay, there is no sympathetic output. Here vasoconstriction doesn't happen because vasodilatation happens here. Here the endotoxin also causes also decreases the catecholamine. It doesn't let the catecholamine to release. So again vasodilatation happens. So whatever the normal pathophysiology happens in normal shock doesn't happen in distributive shock, because vasoconstriction doesn't happen in distributive shock. Everywhere vasodilatation is happening, no sympathetic output, again vasodilatation is happening. So what happens when vasodilatation is happening? We have read beautifully. See what we have read. Whenever resistance decreases. When does resistance decrease? Resistance decreases when there is vasodilatation. When the gates are open, so there will be low resistance and water goes freely. So this is the one concept. And vasoconstriction happens. Whenever vasoconstriction happens, resistance increases, means when the gates are closed, the water tries to push forward. So the resistance increases, the resistance for which the water has to flow increases. So work has to be done more. So heart has to do more work. So whenever vasodilatation happens, systemic vascular resistance decreases and the afterload increases. Now what is the afterload? This afterload is nothing but your cardiac output. So now let's see again. So imagine heart, preload, the amount of blood coming into the heart. This is afterload, which is nothing but your cardiac output, amount of blood going out. So this is a very beautiful concept. Please listen. In hypovolemic shock, there is decreased cardiac output. So there is vasoconstriction. You know this till now. Beautiful, right? Then in distributive shock, whether it's septic, whether it's anaphylactic, whether it's neurogenic, there is vasodilatation. हो गया? अभी next let's see. So there is vasoconstriction. So इतना बड़ा vessel become this small. So in order to push blood through the small vessel, what happens? The heart has to do more work. So vasoconstriction happens. So the resistance increases. In vasodilatation, what is happening? अच्छे से there is vasodilatation ना, इतना बड़ा vessel है. So the resistance is low. So whenever the resistance is low, the cardiac output is more na. So more amount of blood starts coming. So here what happens? Because it becomes thin, only less amount of blood is going because of high resistance. So the cardiac output decreases, the cardiac output increases. So what is the reason for increased cardiac output in distributive shock? Is the resistance is low. Low resistance is the reason for increased cardiac output. Now let's solve. How beautiful is it? See. So hypovolemic shock, what happens? The cardiac output is decreased. Nice. In cardiogenic shock, what happens? Again, the heart is not able to function normally. Again, cardiac output is decreased. Obstructive shock, the example is cardiac tamponade. Again, the heart is not able to pump normally because blood is filled, like na, that piggy bag appearance in cardiac tamponade. So again, cardiac output decreases. In distributive shock, what we have studied, your systemic vascular resistance is decreased. So what is happening to your cardiac output? It is increased. Okay. Then systemic vascular resistance, high systemic vascular resistance. Why? Because of vasoconstriction. See here, low systemic vascular resistance again. Because why? Vasodilatation. How beautiful is it? See. So what does venous pressure signify? Venous pressure, what happens in venous pressure? So in hypovolemic shock, obviously the body doesn't have any blood, na. If body is not having any blood, what will body do? Obviously the venous pressure is low, na, because I told you the amount of blood which is coming into heart is only low, the preload is only low. So obviously the venous pressure is low. So what is happening in your cardiogenic shock? I have told you, see, blood is coming properly, blood is going into right ventricle, blood is going again to lung, blood is coming normal, but here the blood is not able to pump it normally. So what happens? All the blood, indirectly the blood is going backflow from left atrium to the lung, from lung to right ventricle, from right ventricle to right atrium, from right atrium to all the veins, whatever the veins, your IVC, your SVC. So what happens to your venous pressure? Venous pressure is increased. See how beautiful. Here the blood is only not there, na, so venous pressure decreases. But in cardiogenic and obstructive, the venous pressure is increased. Base deficit, obviously in everywhere there is lactic acidosis, so base deficit is increased everywhere. What is mixed venous oxygen saturation? This is beautiful saturation. So imagine this is hypovolemic shock. This is normal blood vessel taking 100 molecules of oxygen. The normal tissue is utilizing 80 molecules and giving back 20 molecules. 20 molecules of oxygen is coming back, going in, getting utilized and coming back. Imagine in hypovolemic shock. In hypovolemic shock, what does it happens? There is vasoconstriction, one thing. And second thing, there is decreased cardiac output. Okay, this is the second thing. So what is happening? Nothing but the circulation is hypodynamic circulation. Okay? Hypodynamic circulation, third thing. So what is happening? So the blood is going slowly and coming back. The tissue is not getting enough oxygenation, right? That is what hypovolemic shock is happening. The tissue is having hypoxia, the tissue is having acidosis. So what does the normal patient, only this, I told you, only 80 molecules of oxygen is getting utilized. But in hypovolemic shock, if at all 100 molecules of oxygen is going, the body is so eager, this tissue is so eager to take so much amount of oxygen because it is not having oxygen, na? So it takes 99 amount of oxygen. Only one oxygen is coming back. So the mixed venous oxygen saturation is falling. So this is now only 120 is becoming 1. So the mixed venous oxygen saturation is falling in hypovolemic shock. Same is with cardiogenic shock, same is with obstructive shock. Now see, this is distributive shock. I told you distributive shock is nothing but leaky capillaries. What do you call edema? There is vasodilatation. See, I have kept big vessels. That's why big vessel, big limb. Okay, vasodilatation. So what happens? It is already because of vasodilatation, all the fluid is getting accumulated, right? And about distributive shock, what happens? The cardiac output gets increasing. So there will be lot of blood coming. But the tissue doesn't want that much, na? Because already, imagine, from this fluid, the oxygen has to go. How does it penetrate itna fluid? So if at all the 100 molecules of oxygen goes, the oxygen can't penetrate through this leaky fluid capillary which got accumulated. So almost 90 oxygen is coming back. So the mixed venous saturation is increasing. Okay. So this is what distributive shock happens. So what happens, until sometime the body tries to compensate with catecholamines, tries to vasoconstrict all these vessels. But after some time the response to catecholamines stops. When the responsiveness to catecholamines stops, then it is decompensated shock. You know what is SIRS? You know what is the pathophysiology of shock? So heart rate increases, heart rate greater than 90. Respiratory rate increases. Okay, respiratory rate greater than 12, and WBC and greater than 4K or less than greater than 12K or less than 4K. This is SIRS score. Triad. What are the triad of SIRS? Heart rate, WBC, and respiratory rate. What is modes when two or more organ gets involved? Some imagine the kidney is getting involved by decreased. How kidneys get is involved by decreased urine output. Okay. Imagine the heart is getting involved. Imagine any circulatory system is getting involved. When two or more organs are getting involved, then you call it as mods. Imagine liver is getting involved. Imagine hepatic enzymes are dearranged when two or more organs are involved. Okay. See, now I have already discussed this before. How do you differentiate between cardiogenic shock and hypovolemic shock? I have already told you in cardiogenic shock, cardiac output is low in both. But what I have told you, there will be venous pressure. Because there will be backflow, na? Everything is same between cardiogenic shock and hypovolemic shock. Only the venous pressure is the differentiating factor. See, everything is same. Only the venous pressure is the differentiating factor between hypovolemic shock and cardiogenic shock. Whereas between cardiogenic shock or hypovolemic shock and distributive shock, what is the only differentiating factor? What are the differentiating factors? The mixed venous oxygen saturation is a differentiating factor. The cardiac output is a differentiating factor. Let's see. Mixed venous oxygen saturation, okay. The cardiac output. The systemic vascular resistance is also differentiating factor. Systemic vascular resistance, what happens? So vasodilatation happens. So the resistance falls. SVR falls. Okay. Cardiac output is a differentiating factor. Systemic vascular resistance is a differentiating factor. Mixed venous oxygen saturation is a differentiating factor. Yes. And some MCQs, they will ask about this. See, whenever they'll tell you a patient presented, first always check the vitals of the patient. If the pulse rate is normal, and urine output is also normal. Okay, pulse rate is normal, urine output is normal. Mostly it is grade 1 only. Nothing more damage has happened. Imagine the pulse rate is starting increasing. So imagine the pulse rate is now roughly 100 beats per minute. Normally it's 70 to 80, 100 beats per minute. And urine output is slightly reduced. But BP is normal, BP is maintaining. Then it's grade 2. Imagine the BP starts falling. Then it's grade 3. If BP starts falling and urine output starts falling, it's grade 3. So if urine output is 0 and the patient is getting drowsy, it's grade 4. See how beautifully it is. Pulse rate normal, urine output normal, nothing to worry. Pulse rate is slightly increasing and urine output slightly decreasing, but BP normal, it's grade 2. BP falls, it's grade 3. Bas. See how I have depicted the same thing in the diagram. Pulse rate starts increasing, grade 2. See, BP starts falling in grade 3. Pulse pressure starts falling is in grade 2. Urine output almost nil in grade 4, but it significantly falls in grade 3. Respiratory rate almost keeps on increasing. Okay, fine. Based upon blood loss, if 0 to 15% of the volume is lost, it's 1. 15 to 30% is 2. 30 to 40, it's 3. Greater than 40, it's 4. See, 15 to 30, it's grade 2. 30 to 40, it's grade 3. Greater than 40, it's grade 4. I think I have covered all the basics about shock. If anything, any things you want to know, any mistakes I have told in this video, please do comment. Please do follow Average Surgeon. If you want to get follow about the everyday MCQs, please do DM me. I would like to add you in our study group. Thank you.